Hello and welcome to this stroke assessment update. My name is Eric Ernest. I am an emergency physician here at Nebraska Medicine. I also serve as the division chief for pre-hospital and emergency medical services and also the state EMS medical director for the state of Nebraska. And I want to thank you for joining us as we're going to talk today about some of the updates that we're going to make to the statewide stroke assessment protocols and the tools that we're going to be using to help assess the patients in the pre-hospital realm when they're presenting with stroke-like symptoms. So with that, we'll get started. So let's talk about why does stroke recognition matter. So as many of you are probably aware, have either run into in their personal lives or in their professional lives of someone who has had a stroke. And we all know how much disability and even potentially death that this can cause. And that EMS really does play a pivotal role in these patients' lives, and the ability to recognize someone having a stroke early and to be able to route that patient to the correct facility in order that they get definitive care plays a huge role in whether these patients will return back to their normal everyday lives. And so when we really think about all the things that we do in medicine, stroke is one of those areas that really EMS plays a hugely pivotal role in these patients' overall outcomes. And it's our ability to, again, quickly recognize those stroke-like symptoms and be able to get them to the care that they need. So this is the state model protocol for stroke. For those who are not aware, we had recently published a modified and updated version of all the state protocols, and those are also available on an app that's available through the Department of Health and Human Services EMS division. And so if you haven't had a chance to download those, I would suggest doing those. And so the comments I'll be making as a part of this presentation will largely focus around the state model protocol. And so we'll be kind of going through some of that. So this is just kind of a general overview, and then we'll get into some of the specifics as to what we're going to be looking for with these patients. So starting out at the top, we always like to think of, in terms of when we are encountering a potential stroke patient, history is vitally important, and we'll go through several of the reasons for that. But things that we really want to ascertain from our patients as to if they're presenting with stroke-like symptoms or a concern for stroke, certainly if they've ever had a history of prior stroke or TIAs, any kind of cardiovascular history, so if they've had a history of heart attack, stents placed in their arteries because they have peripheral vascular disease, things like that. Risk factors that are associated with cardiovascular disease, such as diabetes, high blood pressure, coronary artery disease, other cardiac conditions like atrial fibrillation, which if not properly treated, can actually put the patient at risk for stroke. And then certain medications like blood thinners, when we think about our hemorrhagic strokes and when we're concerned about an intracranial bleed, we always have to think of if they're on any kind of blood thinning agents at baseline and that putting them at an increased risk for hemorrhagic stroke. And then certainly any kind of history of trauma, falls, things of that nature, especially in the elderly population, we always have to think of, was stroke a underlying cause of what led to their trauma? So moving over to signs and symptoms, when we think about things that they could be presenting with, not every patient is going to present with that classic, maybe, right side facial droop or something of that nature. That some of these things can be a little bit more nuanced, and the new screening tool that we're going to be addressing will also address some of those nuances. But things like altered mental status, if the patient's not just acting their normal self, if family's saying, normally they're very talkative, awake, alert, interacting with us, and now they're just not doing those things anymore, those would be concerns. Any kind of apparent weakness or paralysis, especially if it's lateralizing to one side of the body. The things in terms of visual symptoms, blindness or other sensory loss, that's going to be captured within our new stroke assessment tool. Things like aphasia or dysarthria, difficulties with speaking or expressing themselves, an episode of syncope, or if they pass out, thinking of things that would cause some kind of restriction in blood flow to the brain can certainly lead to that. Vertigo and dizziness, a very common one where people might say, I feel like the room is spinning, or I feel like I'm going to pass out. And especially in the elderly population, people with those other risk factors for cardiovascular disease, that could be actually your only indication of stroke. Isolated vomiting, headaches, if they've had a seizure, any kind of respiratory pattern change. Also, if they're presenting with marked high blood pressure, hypertension, or low blood pressure, hypotension, both of those things could potentially lead to stroke depending on what's actually going on in the brain. And so when we think about, when we encounter one of these patients that's maybe experiencing one of these signs or symptoms, the thing we always have to think about is what could this possibly be? And certainly this talk is about stroke, but also maintain a very wide differential when it comes to what could this possibly be. So things like, certainly TIA or transient ischemic attack, seizures, a Todd's paralysis, which for those who are not aware, that's basically if someone's had a seizure, they will present with a hemideficit where, basically half the body is not working like it should. Very, very difficult to distinguish pre-hospitally between a stroke and a Todd's paralysis, and I would honestly treat all those patients as if they were having a stroke. Certainly stroke itself, whether it be thrombotic or embolic, which is about 85% of the cases, and then the other 15% are composed of hemorrhagic strokes. Certainly tumors, so any kind of primary brain malignancy can certainly lead to some of these symptoms. Trauma, if they've had a fall, a head injury, that type of thing. And then some of our patients that fall into the dialysis or renal failure, they can get electrolyte disturbances, toxic byproducts when their kidneys are not working that will build up in the central nervous system, and certainly can lead to some of the signs and symptoms, but they may in fact not be having a stroke. So again, maintain a very wide differential. And I forgot to mention hypoglycemia is one of the great masqueraders. So someone presenting with low blood sugar can have very profound, almost exactly like a stroke presentation, and in fact it's just their low blood sugar. So we'll talk later about the things we need to do for these patients, but checking blood sugars is going to be vitally important in these patients. So things, as we mentioned when we talked about that differential diagnosis, the big mimics that we should always consider when dealing with a stroke patient, I had mentioned on the previous slide, hypoglycemia. So always making sure we're checking a blood sugar with these patients. As I mentioned, seizures can often present with some of these symptoms, and so especially when that patient is first coming out of their seizure and having that postictal state, or kind of that where their brain is still a little bit stunned and not quite functioning the way it should, some of those symptoms can also resemble stroke-like symptoms. Bell's palsy, which is one that we see, it can happen in all populations, tends to happen maybe a little bit more in the younger population, where you have that what looks like a stroke with half the face kind of sagging or being unequal to the other side. Again, very, very difficult to differentiate in the pre-hospital realm. And so if there's concern, especially if it's an older patient, they have some of those risk factors, I would treat those patients just the same and not try to distinguish between a Bell's palsy and a stroke. Migraine, these can also be a great mimicker as well. So what we call complex migraines, where it's someone that has a migraine history, but then that is also combined with them having neurological symptoms at the same time. And so again, you can see numbness, tingling, maybe an arm is not working, they have motor weakness, something of that nature. And those can also mimic strokes, and again, it can be very, very difficult to differentiate pre-hospitally. And then always throwing in their intoxication, people that have succumbed to the use of drugs or alcohol, they may have slurred speech, they may have gait disturbance where they're not walking correctly, things of that nature that again may be difficult to distinguish. So going through our stroke protocol, we're just going to kind of break it down by each section of the protocol itself. So if we go through those signs and symptoms, we kind of work through that differential, and we identify those. The first thing that we're going to do is perform and document a validated pre-hospital stroke identification screen. And I just want to say at the beginning here that there has been some confusion, especially as I've given this lecture and others throughout the state, that previously when we had the Cincinnati pre-hospital score and the RACE score, people sometimes interchange those as if one versus the other could be used. And the idea is that we're going to basically do two different scoring tools if they have an initial positive screening. And so where the change is going to be and why we're giving this update is that in this initial identification screening tool, we've previously used the Cincinnati Pre-Hospital Stroke Scale, and that has been around for a very, very long time. And we'll go through some of the reasons why we decided to implement this change, but that will be our initial screening tool. If we screen positive, we're going to go through, and we'll talk about each part of the protocol here in a second, but then we'll do the RACE score, which we're going to review again in this video just as a refresher. I know it's been already educated on a statewide basis, but again, we're going to be using both of these tools, and they're not meant to be used one instead of the other. They're supposed to be used in conjunction with one another. So let's talk about our new scale. So we went from the Cincinnati Pre-Hospital Scale to what's called BFAST. And the reason we did that is that the Cincinnati Pre-Hospital did a great job at identifying those big strokes that deal with kind of the middle part of the brain, and they're probably the most common kind of strokes. But what we've realized as we've kind of learned more and seen more stroke cases, that there's a lot of patients that can deal with strokes that have happened in the back part of the brain or the posterior circulation, dealing with the cerebellum and the occipital cortex, that really isolated strokes in those areas are really not going to screen positive on our Cincinnati pre-hospital scale. And so when we look at these patients, we're going to say, well, if all we did was the Cincinnati, we may be missing a decent number of the patients that may be having isolated posterior circulation strokes. So the BFAST is the tool that we're going to use to try to capture more of those patients. The first is balance, and so this is the idea that if anyone's had this sudden onset of balance difficulties, they're walking with an unstable gait, anything of that nature, those people are going to screen positive. The other big one is eyes, and so any kind of eye symptoms, whether or not they're not looking in a straight way, they've lost vision in one or both eyes, any kind of visual symptoms are going to be the ones that we're going to look for in that case. And then the ones that we classically thought of during our Cincinnati pre-hospital scale, any kind of facial deficit where there's either numbness, drooping on the side of the face, the arm test where if they've had sudden weakness or if their arm is starting to drift, speech difficulties, and then the T of BFAST is a terrible headache, sudden onset, those types of things. We'll get into a little bit more detail with each one of these. The screening tool, as we go through, really we only need one of these to screen positive. And so unlike the race where we have to have a certain score to say that yes, this is a large vessel occlusion, any of these, just like the Cincinnati pre-hospital scale, will count as a positive, and that will say yes, we have a concern that this patient is having a stroke. As I mentioned, this is adding in those balance and vision symptoms in addition to the traditional symptoms that we use with the Cincinnati. And again, trying to get more of the anterior and posterior circulation stroke identified in the pre-hospital realm. So, as I mentioned, balance. So any kind of sudden loss of balance or coordination. And I like to say with these patients, if they feel like they can't stand up straight, I had one patient specifically in the ER that he said, you know, I woke up from sleep and all I kept doing was veering right into the wall as I was trying to walk down the hallway to the bathroom. He had no other symptoms, no numbness, no tingling, no facial symptoms. All it was this isolated balance component that he just couldn't walk straight. And sure enough, he did in fact have a stroke in his posterior circulation. And this also may present as a dizziness or a vertigo, feeling like the room is spinning around them. Certainly a lot of people get vertigo, especially in a younger population. But again, if this is older, they have risk factors. Really probably anyone above the age of 40 that's presenting with vertigo or dizziness that we don't have an otherwise good explanation for, we want to be at least considering that this is a possibility of stroke. Then we added in also the eyes. So as I mentioned, any kind of sudden vision changes. If the patient's saying, okay, all of a sudden, normally I see just fine, maybe they wear corrective lenses, and now things are remarkably blurry, completely off of baseline, or I'm starting to see double, or if there's a complete loss of vision in one or both of the eyes, those are all things that we would consider as a positive for this screening tool. And then gaze deviation. So this is the idea that if you're asking them to track you with your fingers and you're moving your finger across their in front of their face, and their eyes start coming across, and then they just stop at the midline, they don't continue on to the other side. This is really, or if they're fixed in one direction, let's say you're asking the patient to look at you, and then their eyes are gazed off to the right or the left, and they can't maintain that forward gaze. Any of those types of visual symptoms are going to be considered positive. So these should all be pretty familiar from the Cincinnati, but we'll go through them just as a refresher. So face, so we're looking for facial droop on one side. Typically we'll ask the patient to smile or show us their teeth. And what we're really looking for is any kind of asymmetry in the facial structures. The thing that I always look for first, because sometimes this can be very, very subtle, is basically we're looking at the nasolabial fold. So basically the line that goes from the corner of the nose to the corner of the mouth. Typically when someone smiles or shows you their teeth, that should create a line or a indentation. And a lot of the patients that are having strokes, they will actually have, that'll be one of the first things that's lost, is that nasolabial fold will look different than the other side. And they may not have the huge, what looks like their entire face is caved in or something of that nature. It may just be as subtle as that loss of nasolabial fold. So I'll look there first, then obviously look at their eyes and all the rest of the parts of the face to look for that asymmetry. The next part is going to be arms. So if there's any weakness or numbness, especially lateralizing to one side. So what I'll typically ask the patient to do is to hold both arms up straight ahead of them as if they're catching a big giant beach ball, and then ask them to close their eyes. And what we're looking for is for the ability to maintain both those arms straight up like this with their eyes closed. If we start to see that arm start to drift down a little bit, typically they'll start to kind of turn inwards. And certainly if it's a profound loss of muscle tone where the arm just drops quickly, those would all be considered positive signs for arm weakness. The next one we're going to talk about is speech. So anything that sounds slurred, garbled, incomprehensible, And sometimes the patient won't notice this themselves. It'll often be a family member who says, you know, my husband, my wife, my mother, father, whoever it might be, you know, normally they're very clear, coherent, and you know, today it just sounds like they have marbles in their mouth or they just can't get the words out correctly. So those would all be indicators of potential speech involvement. And then having the patient repeat back to you a very simple phrase, like you can't teach an old dog new tricks, the sky is blue. There's lots of different phrases that people use. But if they can't repeat this, or it sounds garbled, or they mismatch the words, all those things would be concerning for speech involvement. And then the other big thing, so we talked about terrible headache, also time, so the T is kind of doubly linked here, but in terms of terrible headache, this is someone who maybe doesn't normally get headaches, or maybe they have had migraines in the past, but they say, this is the worst headache in my life. It came on suddenly, it felt like a freight train, or we classically will call this a thunderclap headache, where it was just like boom, all of a sudden, worst headache of their lives. Those would all be concerning, especially for hemorrhagic stroke. And then also with the T is time, and we'll talk about the importance of when did the stroke start and why the last known well is vitally important to these patients. But time is also something that we also need to consider for these folks. Why is time important? And so the part of the protocol is, you know, we use this 24-hour marker, and the reason for that is that, especially for the large vessel occlusion strokes, and we'll talk about the race scale here in a little bit, but anything less than 24 hours, those patients are going to have the potential to have intervention done. And so if it's been, you know, the stroke symptoms started 2 or 3 days ago, these patients unfortunately are not going to have any kind of acute intervention available for them. And we'll talk about kind of routing of these patients and where they go. But the 24 hours is kind of the big mark as to yes or no. But then the last known well is really, if I was going to emphasize any part of this presentation and what really drives the hospital process once that patient gets to definitive care, and when were they last seen normal? And so guessing at this or saying, well, I think it may have been this morning or maybe sometime last night. Really, if we take a few extra minutes on scene, talk to bystanders, talk to loved ones, a spouse, something of that nature to say, you know, when were they truly their last known well? Like I talked to them on the phone 20 minutes ago and they sounded fine then, and then I walked into the room and now it sounds like they have marbles in their mouth or they're not talking properly. Those kinds of specific details are hugely important because the medications and the treatments that we give downstream, if we don't have a good last known well, could potentially impact whether they receive those treatments at all or if they have adverse outcomes from those treatments. And so again, I can't emphasize enough the idea of last known well really does drive the entire process once this patient arrives to the hospital. As we kind of mentioned, getting this nailed down is hugely important. And so the idea of the 24-hour time period being important, but then also the 4.5-hour time period. And so anything less than 4.5 hours, and we have to remember this is from the time that the stroke symptoms started to when the patient is actually in the emergency department, getting their imaging studies done, and then actually having the time to mix up the thrombolytics, typically TPA or TNK. All that has to be done within a 4.5-hour time window. So when we think about where are these patients going and where should we take these patients, the idea that if this patient is 4 hours and 15 minutes into their stroke and you're still on scene and you have a 30-minute drive to the hospital, they're probably going to fall outside that TPA window. And so especially if they're having a large vessel occlusion stroke, this may be something where we say maybe we should bypass the local hospital and then get them to someplace with more definitive care. These decisions are going to be often in conjunction with your medical director, and certainly every region has a different kind of answer to this question as to how we properly route patients. Certainly like within a metro area, you know, whether a primary versus a comprehensive, that's a little bit more of an easy decision. If you're in a very rural area where maybe your closest hospital is an hour and a half away, this may not be as much of a factor because you only have one option. So again, working with your medical director and within the local region to identify how best to route these patients is going to be important. In terms of, you know, as we mentioned last known well, getting as much background from family, coworkers, et cetera. If you can also obtain a phone number of a good contact, so let's say it's a husband and wife and the husband is having a stroke, maybe the wife can't ride with you, but having a phone number that we can contact that person who knows what was happening would be hugely important as well. And then again, documenting the actual time as opposed to generalized time frames like this morning. If we can say 7:42 versus sometime after breakfast, the more detailed, the better. And then if this patient is a wake-up stroke, so let's say they woke up in the morning and their face is not equal to the other side of their face, or they're having arm weakness, and all of a sudden they're like, well, it was last night sometime, I think I went to bed around 10, I was feeling fine then, but then I woke up with these symptoms. Anytime it's what we would call a wake-up stroke, their last known normal is going to be when they went to bed that previous night. And then obviously making sure we're recording all this in our patient care reports, because those things do go on and stay with the patient all the way through to definitive care, and that way we all have the same details as they progress from, say, one facility to another. So as we're moving through our protocol, that first question that we're asking is, was the onset less than 24 hours ago? And so if the answer to that question is no, meaning they're outside of a 24-hour window, their treatment options are going to be markedly limited because a lot of the damage from the stroke has already been done. So these patients we're going to transport to our nearest certified stroke center, whether that's an acute stroke ready hospital, a primary, a thrombectomy capable center, or even a comprehensive. But really it's just going to be the nearest facility to start initiating that treatment. If this is less than 24 hours where we do have that treatment window available to us, the next step is we're going to be performing the RACE score. And so what we're going to get into that as a little bit of a refresher. Hopefully you've had this education already on from the statewide initiative that we had a few years ago, but we'll go through some of the particulars here just as a quick refresher. So big thing we're going to look for as we calculate the score is whether or not they're above or below 5. That will kind of dictate whether or not we're concerned for a large vessel occlusion in these patients. So going through the scoring system, this should look pretty familiar to most, but as a quick refresher, we go through facial palsy, arm and motor function, leg, head and gaze deviation, and then if the patient's having symptoms on the right side of the body, we're looking for things like aphasia or difficulty with speaking, or if it's on the left side of the body, agnosia, which is the inability to recognize familiar objects. And we're going to go through each one of these things individually. And so a lot of these are going to be a score of 0 to 2. One of these, in terms of the head and gaze deviation, is kind of a yes or no question. If it's negative, they'll get 0 points and 1 point if they have that. But the rest of them, it'll be a score of 0 to 2. And again, we'll go through some of these individual scores. So in terms of the first one, looking for facial palsy, again, we've probably already done this part as with the BFAST exam. But we're going to go ahead and record the score here. So a 0 means that there is no problem. Their face looks normal. You ask them to show their teeth. Everything looks symmetrical. There's no loss of that nasal labial fold. So again, no symptoms. We'll call that a 0. If it's moderate or severe, where there's a huge asymmetry, you can look at it from across the room and say, yes, that patient's face is not equal. We're going to give that a 2, and then the kind of in between is going to be a 1. So maybe if there's a little bit of a drooping of the eye, again, that loss of the nasal labial fold, those would be considered mild symptoms, and we give that patient a 1 for that. And so for our arm motor function, again, this would have been already done as a part of our BFAST exam. But if the patient is sitting in a chair, we'll go ahead and have them extend their arms out to 90 degrees like this. If they're sitting, supine on the cot, let's say you've already got them onto the stretcher and they're kind of in that recumbent position, just having their arms out at 45 degrees will work. And so we're going to have them hold their arms straight up in the air, have them close their eyes, and then what we're going to look for is starting to see if they have any drift of that arm. And so sometimes this can be very subtle. It can be just a little bit of an inward turning of the hand, as demonstrated in this picture here, or it can be just a complete loss where you're holding their arms up and say keep them here, and that one just drops straight to the ground. Obviously, that would be a more severe symptom. So if they can keep both arms up, that would be normal or mild, and we'll give them 0 points for that. And we want to be able to do that for 10 seconds. If it's severe, where that arm just immediately drops, they can't keep it up against any gravity, that would be a 2. And then if it's in between that, where maybe they start to have a little bit of that inward turn, or maybe the arm is kind of bobbing as it's going down, that would be considered a 1. So similarly with the lower extremities and testing the leg motor function, we're going to have them laying down, typically on the cot. And so we're going to have them raise their leg up off the bed about 30 degrees. And so if they can keep that leg there for about 5 seconds, we're going to say that's normal and we'll give them 0 points. If it's something where we hold their leg up and say, keep that leg up, and it immediately drops back down to the bed, we're going to give them 2 points for that. And then similar to the arm function, where if they can kind of keep it up, maybe the leg is bobbing a little bit, it kind of gradually goes down to the bed, that would be considered a 1. So this is the one where we're only going to give 0 or 1 points for head or gaze deviation. So this is really where we're going to look at the patient, and this could be very obvious on initial evaluation where maybe the gaze is already deviated. You're asking the patient to look at you and their eyes are maybe tracked off to the right or the left. But if there's any question, this is where we can have them do a simple exercise where having them follow your finger just with their eyes. And so if you're bringing them past midline, and let's say their eyes stay off to my right and you're starting to bring that finger to the left and they can't get past midline, or they're stuck off in one direction, any of those types of things where the eyes are not tracking appropriately is going to be considered gaze deviation. So if there's no evidence of that, they're going to get 0 points. If it is present, they're just going to get 1 point. There's no in between on this one. So this is one I think can cause a little bit of confusion here. And again, trying to identify, okay, so which side of the body is the patient having stroke symptoms on? So if this is on the right side of the body, which correlates with the left hemisphere of the brain, there is a crossing of the fibers within the brain. So it might seem a little bit confusing, but the left side of the brain is often responsible for things like being able to understand written and spoken commands, things of that nature. So if they're having right-sided symptoms, we're going to be checking for aphasia. So we'll ask the patient to do a couple simple things. We can say, can you please close your eyes and make a fist? And so if they can do both those things, they close their eyes and they can make a fist, we can say, okay, that's normal. Let's say they can't do either. You ask them to do both of those tasks and they just kind of stare at you blankly, or they're not able to perform those. We would give that a 2. And then let's say they can kind of close their eyes, but their hands are not doing a whole lot. That would be a 1. So conversely, when we're looking at agnosia, this is the ability or inability to recognize familiar objects. And so you can actually ask the patient by holding their own arm up, whose arm is this? And they could sometimes just look at you and say, I have no idea. Or you can ask them to identify a familiar object. Maybe they have a spouse or a loved one saying, who is this? And they'll just be like, I have no idea. And so any of those types of things, we would say if they don't recognize any of those things, that would be a 2. If they can say, yes, this is my arm, yes, this is my spouse, this is my leg, whatever it might be, that would be a 0. And then if there's maybe one of those things they don't recognize or they're having troubles with that, we would give them a 1 for that. So why do we do this whole race scale thing? Because there's strokes that can be very, very mild. There's strokes that are very, very severe. And when we think about why we do the race score, we're really looking for LVOs, or large vessel occlusions. And so these will account for about 30% of our strokes. And these are the ones that, although we do give the clot busting medication like TPA or TNK to these patients once they get to the hospital, oftentimes they will need additional therapy in order to completely resolve that clot. And so a lot of these patients will have to undergo what we call mechanical thrombectomy, where we'll have a surgeon typically go in through one of the vessels, they'll snake a catheter up to that part of the brain, and then they will physically remove that clot through a variety of mechanisms to try to restore perfusion to that part of the brain. And unfortunately, not every hospital is capable of doing that. And so the stroke centers that are labeled either a comprehensive stroke center or a thrombectomy capable stroke center will have the ability to do that specific procedure. So if our race score is above 5, indicating that we suspect a large vessel occlusion, it's very important that these patients get routed to a center that is capable of taking care of them in as timely of a manner as possible. And so again, if we can detect this early on the front end, if we're there within 20-30 minutes and we're saying, yes, this patient has an LVO or a large vessel occlusion, and we can get them to that definitive care, it is amazing that these patients that maybe 10-15 years ago, where they would have these huge neurological deficits, they would be in long-term care facilities and nursing homes for the rest of their lives because half their body is now not working. These are patients that are now walking out of the hospital completely neurologically intact. So again, this is where EMS plays a huge and pivotal role in early detection of these patients and their ability to get them to definitive care. So we've identified if they're under 24 hours. We've performed our severity score, which is that race score. So again, if they screen positive for the BFAST, we're less than 24 hours. Let's say they don't have that large vessel occlusion, so their race score is less than 5. Again, we're going to transport those folks to the nearest certified stroke center. If it is in fact greater than 5, this is where we're going to be starting to consider, can we get them to a thrombectomy center? And while I could try to go into all the different nuancing and possibilities, this is really where working with your local medical director and the local hospital system and knowing what resources you have available in your region are really going to dictate how this works. And so whether or not you're going by ground or going by air, if you go to the closest facility, because say it's 5-10 minutes away, but they can land a helicopter there and get them to a thrombectomy capable center or a comprehensive stroke center, those are going to be the situations that you're going to have to kind of work through on a regional basis to be able to identify how does this patient best get to definitive care. So again, time is brain. These folks, the brain is dying or being injured at a very rapid pace, especially if they have a large vessel occlusion. So again, if we have the possibility of bypassing a non-thrombectomy capable center, if those local protocols allow for that and getting them to someplace that can actually intervene on this, that is huge. The other thing I would mention is the pre-arrival notification. So this more quickly that we can notify the hospital, even if we're going to say a primary stroke center or a acute stroke ready hospital, and letting them know, hey, I have a stroke patient, our local protocols say I have to come to you first, but this looks like it's a large vessel occlusion. That receiving hospital can actually start making some efforts to say, putting a helicopter on standby or already arranging for that secondary transfer to a higher level of care, and thus shortening that time where the patient, from the time they've had their stroke symptoms to getting that definitive care like a thrombectomy. So some other considerations that we want to think about, and these things are again, just considerations. They're not absolutely mandatory, but when we think about when these patients arrive at a facility similar to ours or really any kind of stroke center, getting a right side IV, that may seem a little bit kind of nuanced, but the way in which a lot of these CT protocols for stroke are timed and using the right side versus the left, we tend to get better pictures and better identification of stroke if the IV is on the right side. So if you can get it on the right side, great. If all you have access for is on the left side, let's say maybe they've had previous injury to that right arm or something of that nature, left side IV is perfectly fine, but if you can get right, that'd be very much appreciated. And then the idea also that we want to touch on is the difference between a CSC or a comprehensive stroke center and a thrombectomy capable center. Both of these centers are technically able to do that mechanical thrombectomy procedure, but when we think about where these patients ultimately end up, the comprehensive stroke center is going to have a lot more additional resources in terms of neurosurgery availability and some of the critical care services that are needed to treat some of our sickish patients. And so if there is a ability to go to one versus the other, and this patient is having that large vessel occlusion, and there's really not a huge time difference, usually the comprehensive center is going to be the preferred modality. But again, I would defer you to your local regional protocols and your medical director in that area to figure out which of these centers is most appropriate. So I just want to thank everyone for joining us for this presentation, and hopefully have gotten some additional information as to what the impetus was behind changing the statewide protocol, especially the BFAST, to try to capture again some of those patients that are having more of those posterior circulation symptoms. And certainly if there's any questions or concerns, I would recommend that you reach out first to your local medical director or local hospital and stroke center, as a lot of times they will be the ones to help coordinate these patients' care. And certainly if there's any other questions that go unanswered, you can certainly reach out to us at Nebraska Medicine through our stroke program, and we'd be happy to assist you in any way we can. Thank you again for your time.